So Cornerloc is a new procedure that allows us to stabilize the SI joint from a posterior approach. So Cornerloc is selected for patients who failed conservative care to treat sacroiliac joint pain. What we've seen over time is that 20% of patients who suffer from lower back pain, it's not coming from their lower back or lumbar spine itself, it's actually coming from the SI joint. The SI joint is, it stands for sacroiliac. So the sacroiliac joint is what attaches the spine to the pelvis. This joint isn't supposed to move, and if it becomes mobile due to natural degeneration, focal trauma to the area, or prior surgery, then when that joint becomes mobile, it starts to cause patient's pain. So there's two types of patients we're going to see. We're going to see patients who come in and have naturally developed pain over time. And when you work them up, you'll see that the pain is over the lower back or buttock area. There's specific exam maneuvers that we can do that'll localize it to the SI joint. And at that point, we suspect that they have primary arthritis of the SI joint that's become symptomatic over time. Second scenario will be patients who have had no prior back issues or problems. They either suffer a fall or a motor vehicle accident, and the trauma from the accident leads to a shearing force across that joint. And those patients, it's the same thing. They'll come in, they'll complain of pain over the lower back, buttock area, and the same exam maneuvers that we do for a patient with primary arthritis. We'll put them through the same maneuvers and see that those maneuvers cause the pain over the SI joint. The third scenario that we'll see with patients with this condition are patients who have prior lumbar surgery. And so if you look at patients with lower back pain with no lumbar surgery, statistically we'll see that about 20% of those patients have SI joint dysfunction. But once patients have had a spinal fusion, we see that up to 40% of patients with continuous or persistent lower back pain following the surgery, it's usually the sacroiliac joint dysfunction. And what happens is that a spinal fusion doesn't allow their lumbar spine to move anymore. So the levels above and below the fusion now have to make up for the lack of motion at the levels of the fusion. And so the SI joints become mobile as a way to help the patient be able to move since the rest of their spine is fused. We do the standard of care, and meaning that we always want to start with the least invasive treatments. So we'll put patients on topical medications, maybe some oral medications, and try to get them involved in a physical therapy program and hope that their pain complaint's not going to go away. Typically after they've done 4 to 6 weeks or 3 months of conservative care, if they haven't improved, then we'll look at potentially doing an SI joint injection. A patient will come to the office, I'll use an x-ray to guide, and I'll actually put a needle into the joint and inject it. I like these injections for two reasons. One, the injection is diagnostic, and two, it is therapeutic. So what do I mean by diagnostic? Meaning that if I put a needle into that joint and I put numbing medication in the joint and the patient's pain goes away, then that really confirms to me that the pain is coming from that joint. If I put numbing medication into that joint and the pain doesn't go away, then that tells me then right then and there that joint isn't the source of the patient's pain, and we look at other options in that area that could be causing pain. It's therapeutic in the sense that, after I put the numbing medication in the joint, I then put a steroid. Steroid isn't an instantaneous thing. It usually takes 1 to 2 weeks to kick in. So I always tell patients to get an SI joint injection that if the injection is going to work, I expect them to have immediate relief following the injection that day for several hours while the local anesthetic is working. And then it can take 1 to 2 weeks for the steroid to kick in. So they'll feel good that day, probably no different for a few days, and then gradually get better. Unfortunately, there's no guarantee with steroids. Steroids give patients relief until the day they die, or it could only give them relief for a few days. And so unfortunately, we have to kind of see what happens following the injection. And so I usually have patients follow up 1 to 2 weeks afterwards to see where they're at following the injection. When I start to look at Cornerloc, it's for patients who have failed conservative care, meaning that medications, physical therapy, and a couple SI joint injections haven't resolved their pain. At that point, then I'll look to do something more permanent. And so the Cornerloc procedure then would be a consideration to stabilize that joint so the patient no longer has pain moving forward. This is a minimally invasive surgery, so it cannot be done in my office. It has to be done in a surgery center or hospital setting. Once it's time for them to have the procedure, they'll take them back into the operating room and put them in a position of comfort that allows me to be able to do what they want and allow them to be comfortable during the procedure. I've seen this procedure done on patients under conscious sedation, and I've seen it done under general anesthesia. Once we get them in a position of comfort, then we bring the x-ray unit over and we target that SI joint to make sure that I can see where I need to go. Once again, we use sterile soap to clean off the area where I'll be working, sterile drapes to give me a working area. And then at that point, we're going to make 2 small incisions. One incision above and just medial to the superior part of the SI joint, and a second incision just inferior and medial to the SI joint. Both incisions are about the size of a dime. Through those incisions, I take an instrument called a Steinmann pin. The Steinmann pin is almost like a needle. It's going to go into the inferior and superior parts of the joint. Over the top of the Steinmann pin, I'm going to use a series of dilators to give me a working cannula to put the implant into the SI joint. Once I get the working cannulas in place, I use a small drill to kind of drill an opening in the joint. At that point, I will use a reamer to kind of create edges on both sides of the joint that allow the implant to grow into. And at that point, I will place the implant into both the superior and inferior part of the joint. Since the patient is sedated by an anesthesiologist or put under general anesthesia, there's really no discomfort during the procedure. But can patients be sore afterwards? Absolutely. You know, it's a surgical procedure, so the expectation would be that a patient will probably be sore for a minimum of 2 weeks and maybe up to 6 weeks following the procedure done. Once again, it would be a scenario where we would want to see them 10 to 14 days afterwards and remove their staples, and then follow them out a month later after that. At that point, we'll probably know if the procedure is helping them, and probably want to get them in physical therapy to maximize any function that we can after their pain is reduced. What's great about the Cornerloc procedure is it's done from a posterior approach into the joint. Traditionally, an SI joint stabilization procedure was done from a lateral approach, so there are several companies that utilize that approach. But coming in on a lateral approach, there's complications that can occur. One can be a vascular injury. There's arteries that can be compromised that can lead to a bleeding complication during the procedure. That isn't an issue with the posterior approach with doing Cornerloc. The other thing that can happen is that when you're coming in laterally, you can actually get into the neural foramen where the nerves go down into your legs. And so I've seen cases of patients where they've had permanent nerve damage from having a lateral SI joint stabilization procedure done where that nerve has been compromised. Once again, using a posterior approach with Cornerloc, you can't get into the neural foramen and damage one of the nerves that goes down a patient's leg. One of the other advantages about the posterior approach is, like I was telling you, the patients after the procedure can walk out of the surgery center or hospital. With a lateral approach, the patient is non-weight bearing for 6 weeks following the procedure. And so it's that can hinder patients, especially if they are young and working, you know, who can take 6 weeks off of work and be non-weight bearing. The great part about the Cornerloc procedure and this posterior approach is there's minimal complications. Essentially, the only complication is that the procedure doesn't help their pain, or 2, they develop a soft tissue infection from making the incisions for the procedure. I've been doing this procedure now for about a year and a half, and knock on wood, I haven't seen either one of those complications. So far, my patients have described getting, you know, up to 70–80% relief that's been sustained, and I have not had a single soft tissue infection with doing this procedure. I'm very comfortable in performing this procedure. I've been fortunate to be asked by the company to be a national trainer, so I actually train other physicians throughout the United States on how to do the procedure. And I think that experience has allowed me to develop finer nuances on how to do the procedure, since I've had so much exposure to training people. Plus, having my own personal experience of doing the procedures over the last year and a half has allowed me to fine-tune my surgical technique. I think one of the great things about this procedure is a lot of procedures I do need to be repeated over time. And what I like about this gives me a way to give a patient lifelong pain relief that only takes 20 minutes in a surgical setting. So next, we're gonna have a patient testimonial who's had the Cornerloc procedure done. And so I hope as a patient you enjoy hearing the success that another patient's had from having this procedure performed.